Thank you so much for coming. The Bandar Center for Medical Business Ethics was established in 2007 with a goal to promote ethical business practices in medicine and healthcare. Through research, education, community engagement, we hope to better understand and better communicate the ethical relationships between healthcare professionals, patients, business, and society. Ethics is a remarkable human endeavor. We believe that a better future can be created by engaging one another's unique professional and personal stories. We encourage open dialogue on the issues of medical business ethics by bringing people together in inspiring spaces for thoughtful reflection. Our challenge, therefore, is to hear from voices across the community to take part and to encourage each other on this important journey. So to that extent, the Bandar Center has no physical location, but we find ourselves all over St. Louis, inhabiting, if only for a few moments, a space like this one, the St. Louis University Museum of Art. We are nomadic, a little bit, but in the truest sense. So my highest hope is that today someone here will get a spark from something that was said, or meet someone compelling to collaborate with, start a project, network, invest in something worthwhile, start a company, change the world for the better. So I am thrilled that my guest today is the esteemed Dr. Claudia Fegan. Dr. Fegan was appointed Chief Medical Officer of Cook County Health in 2013. In this role, she provides executive oversight for the health system's medical practices and helps inform health policy initiatives. Dr. Fegan joined Cook County Health with 15 years of practice as an internal medicine physician. She began her career at Cook County Health as the medical director of an ambulatory care center and progressed through the health system, serving as the medical director of Fantas Health Center and the chief medical officer of Southside and Southern Suburban ACHN facilities. Dr. Fegan was awarded the Soul of Medicine Award by Physicians for Social Responsibility for her work inspiring medical students to commit to careers in social justice, and is the 2017 recipient of the Paul Cornely Award for her work as a healthcare activist. She has testified before Congress and is known as an expert in healthcare reform in the US and Canada. She also is certified in healthcare quality and management and is a diplomat of the American Board of Quality Assurance and Utilization Review Physicians. Dr. Fegan is also the president of Health and Medicine Policy Research Group and the national coordinator of Physicians for a National Health Program. Dr. Fegan attended Fisk University in Nashville as an undergraduate and received her medical degree from the University of Illinois at Chicago. So Dr. Fegan, welcome to the Bandar Center.
Thank you very much. Happy to be here.
Thank you. Just to start off, you were at a rally in Chicago at the AMA annual meeting in June, and this was reported on MedPage today, and you can Google Dr. Fegan on your phone, and this is one of the things that comes up first. But you said something very special. They quoted you as saying you were there for people who couldn't be there, right? So can you talk about that event, and what were you thinking of as your role, and just kind of expand on that thought that you were there for the people who couldn't be there?
Yeah, I was advocating for access to health care. There are 28 million people in the United States who do not have health insurance and have difficulty in accessing health care. There are also millions of people who are, I would say, underinsured. And as a result, they may work and may have insurance, but if they have an illness, they're unable to afford the expectations in terms of costs that they have to meet. So what people don't understand in this country is that the majority of people who are uninsured are working people who were born in this country, and for one reason or another, they're not covered. And often their lives, as the lives are of most poor people in this country, chaotic, with unstable housing, food insecurity, and they don't have time to be out advocating for themselves and for the legislative changes we need to make so that they have access to the things they need. And I think that it's incumbent upon us who provide care, who understand the struggles of these patients, to speak out for them, to give voice to those who are voiceless.
Yeah. So the AMA, what's the AMA position on single payer? I mean,
so I'll remind you that the AMA struggles with issues like this. The AMA opposed the enactment of Medicare in 1965. The AMA has been opposed to single payer or improved Medicare for all. And the AMA unfortunately has spent a lot of time advocating for, and it's not something that, it's not that other trade groups don't do that, and the AMA is a trade group. They advocate for the benefits of their members. But there's little stomach in this country for physicians advocating for their pay when they're better paid than the majority of U.S. citizens. And it's not to say that every physician doesn't deserve to earn an honest salary. That's not the point. But they are not those who are struggling the most. Although medicine has changed a lot, and there are a lot of problems that physicians have, and the problems that physicians have also affect patients in terms of the loss of autonomy, the loss of the ability to provide the best care for patients that they think is appropriate. But the AMA has not been a strong advocate for the needs and rights of patients, and that's a problem.
Yeah, and that's really why you were there.
Yes.
I would say. Okay. Interesting. I would like to focus in this event on your role kind of as an activist. I asked you on the phone, is that okay?
Yeah.
Are you an activist?
I am.
Okay.
I absolutely
okay.
am.
And, so let's talk about single payer a little bit, I
Okay.
guess. I'm kind of going to go in that direction because I think that's what you talk about.
I spend a lot of time talking about that.
Single payer is, I would say, more centrally on the political agenda now than it has been in the past.
It's certainly a topic of discussion, but
yeah.
it's one that people often confuse and say, why do you have that name and what does it mean?
Mm-hmm.
But basically what I'm advocating for is I think that healthcare should be a right. Mm-hmm. I think that the United States as a country has accepted the notion that everyone should have a right to public education. I think that we have accepted that there are certain responsibilities we have to each other as a community, as a society. And so what single payer says is that the government would be the payer. And there are a lot of ways we could talk about how we would deliver health care, what we think is the most appropriate way to deliver health care. But the first thing is to ensure that level the playing field, ensure that everyone has access to health care. And the way you do that is the government says, no need to worry about that. We're going to pay for the care that's appropriate for the patients. And so that the doctors can focus on what is the care that the patient needs. And so that people coming into a clinic or a hospital, the first thing is not a registration desk to find out how that visit's going to be paid for. It would be someone asking, how can we help you today? What is the problem that you have that you would like us to address?
Yeah.
So we talk about single payer because I think it simplifies things. It means instead of having hundreds of different insurance companies, that we have one insurer, the federal government, which says we will pay for the care. And every other industrialized country in the world has figured out how to do this.
Yeah,
And the United States is alone in not guaranteeing access for everyone who lives within its borders.
Yeah. I'm thinking, I'm really wanted to explore kind of the evolution of your activism, advocacy, and general ability to promote this idea when it has become more central. I mean, so Bernie Sanders campaigned on it, right, and got really far. Yeah. Right, so I think that wouldn't happen 10 years ago, right? Nobody would be able to do that, maybe.
Well,
who knows?
Actually, I talked to Bernie Sanders about this issue first in 2007.
Oh, sure. Yeah.
So he's been talking about it for a long time.
Right, as a presidential candidate. Okay.
Yes.
So, and so as it becomes more central, I mean, how have you changed? Yesterday, I got a chance to hang out with you a little bit, and you were talking about. Not just any old Medicare for all, but a good Medicare for all.
Right.
We'll talk about that a little bit. I mean, have you shifted from just single payer to talking about more like the nuances, or has this been a change in you?
So, well, I've been talking about this issue for 30 years. So I think that the general public's knowledge of the issues has broadened over the last few years. I mean, when I first started talking, especially in the physician communities, people would say, oh, you're one of those left-wing fringe sort of folks. But everyone understands Medicare. Medicare is a popular program that most people are aware of. I think that one of the challenges with Medicare, traditional Medicare, is that it covers only 80% of medical costs. And if we really believe, and this has been studied and it's been published, that when we have people have to pay a portion of their health care bill, And a lot of people in this country believe that you have to have some financial skin in the game, or you'll be frivolous in your use of health care, or will use health care unnecessarily. That's been proven to be false, but I could come back to that. But Medicare only covers 80% of the cost. And if you really believe that health care should be a right and that everyone should have access, then you shouldn't put financial barriers, even 20% of a barrier, into access to health care. Mm-hmm. So one of the problems I find with Medicare is that it requires the recipients to pay additional costs for any care they receive. And the Rand Corporation did a study back in the 1970s when they used co-payments as little as 50 cents or $1, and they found that co-payments, no matter how small, deter people from necessary care as often as unnecessary care. And so if we're really committed to provide people care, then we can't impose a financial barrier. And what we know is that it's cheaper to pay for preventive services like treating the diabetes or treating the high blood pressure, as opposed to taking care of people after their bodies have been ravaged by uncontrolled diabetes or uncontrolled high blood pressure.
Yeah, and on the flip side, you were talking about people having skin in the game, right, in order for them to not overuse.
Right.
What's going on with that?
Well,
I mean, that seems logical.
It seems logical, but there's nothing to prove it. And so sometimes we think of ideas in our mind, and they take hold and they become popular notions. There are a lot of health economists that say, oh yeah, people have to have a financial skin in the game where they're just going to overuse health care. But other countries don't find that to be the case. And so there's data on that. And so if we're going to make big policy decisions, we should be basing it on data. Mm-hmm. It's not as though if tomorrow everything were free, that everybody who should have a mammogram or colonoscopy will be lined up around the corner to get it. The reality is that people still need a lot of encouragement to do the things that we know are important.
Right.
I think that putting another barrier makes another excuse for someone to not do something that could potentially save their life.
Yeah, okay, got it. Well, so I'm really interested in this idea of becoming a physician activist. You know what I mean? Of being a physician activist, of becoming activated. Here's the question: what kind of a thing is an activist?
So we talk a lot since 9/11 about if you see something, say something.
Yeah. Yeah.
So, but I've been saying something all of my life, I would say.
Yeah.
And I actually became a physician because I thought that would give me a louder voice. So I actually wrote in my application when I was, applying for residencies, that if you have a physician, if you're an MD, or if you have any initials after your name, if you're an MD, if you're an RN, if you're a PhD, you are revered in your community. People listen to you. They think that additional education provides credibility. And for me, I felt that it provided an opportunity to effect change in my community. And what I wanted to do when I conceived of the notion of being a doctor was to be active in my community and to make a difference and to make things better for the people around me. Yeah. And I viewed becoming a physician as a vehicle to do that.
Yes. Yes. And you were successful at doing that. That was the way you viewed it when you started, right?
Right.
And neat. That's something I do want to talk about, is how you got to be you. And really, so what's the difference between being simply politically engaged as a clinician or a physician and then being an activist? Is there a difference there? You know what I mean? Is there something of quality different?
Well, everyone has an opinion.
Yeah, right.
But believing that it's important to make a difference, believing that it's important to try to influence people, believing that it's important to try to affect change. A lot of us will walk past a problem every day and say, that's terrible, somebody should do something about that. And I believe that you can't walk past the problem, you have to stop and say, how are we going to fix it? My mother was a social worker, my father was a labor and union organizer, so I think I came by my activism quite honestly. Yeah. In our house, if you didn't speak up, you were out of the conversation, so assertion was important.
Yeah.
So I think that I increasingly, I think that one of the things in this country is that oftentimes, certainly when I was applying to medical school, the people who we were accepting in medical school were often politically inert. Because we selected, those were the people. We did not select people going to protest and demonstrations. And I can tell you that when I was at Fisk, my parents actually knew the dean of Meharry Medical College, which was across the street from Fisk. The four of them, the dean and his wife and my parents, had shared an apartment in Chicago at an earlier time in their lives. And so I remember being in class at Fisk one day. It was a biochemistry class, and a young lady came over. She had walked across the street from Meharry to my professor, and he had a note, and the note said that the dean of Meharry would like to see me. Oh, wow. And so I was like, oh, wow, okay, okay. So I went over to Meharry, and the dean, who I had known from when I was small, said to me, I understand you were at an Angela Davis rally last night. Now, I did not realize that Nashville was that small a city. But I also didn't know why he was asking me about it. I said, yes, I was. And he said to me, I thought you wanted to go to medical school. Right. And immediately the assumption was, if you were attending this kind of rally, you must not be serious about your studies or wanting to go to medical school. So I think that we give lots of messages to young people about what is acceptable behavior for certain tracks or certain careers. But I was defiant of that because that's not how I was raised. And I think that we have to be mindful of the cues that we give to learners about what it takes to be successful. Mm-hmm.
It's a conservative institution, medicine,
it is,
right? And
slow to change.
You're right, slow to change. It seems, so this is interesting. So one of my questions that I had beforehand, maybe I have to change the question a little bit now that we've had this much discussion, but it seems to me it's a bit easier to have progressive views and participate as an activist when one is still yet unknown, like medical students, right?
Right.
The progressive wave in medical schools, everyone shows up for the single payer, but as people get more established in their career, they fall away. Is that a real?
No, that's true. Real? I think that especially if you aspire to a role of leadership.
Yeah.
I come from Chicago, where politics is a contact sport. Mm-hmm. And so, therefore, there is a tendency, it is rough and tumble. I've had family members who lost their positions because they were in association with folks who might be considered less than acceptable. You have to make a decision at some point about what are the most important things to you. Mm-hmm. So certainly people who are on track to become department chairs or program directors or leadership roles in medicine can be subjected to scrutiny and excluded by those above them who would be offended or concerned or distressed or disturbed by their political views. And I am fortunate enough to work in a system that's in a city where my views are not considered abhorrent. Problematic at times, but not abhorrent. So I have had superiors who, they may agree with me, but they would not stand next to me or want to be. And I was removed from one of my leadership roles once because of my association with one of my mentors. So I understand that there's a cost to be paid, but you have to make a decision about what is important to you.
Yeah. So this really came to fruition, this concept of becoming a doctor so you could have a bigger voice or a louder voice. Is that right? And for you, not only did you become a physician, but you became a leading physician, right? I mean, you were in these leadership positions. So talking about that progression, I think, let's take a break from this, but we're going to come back to that a little bit. Okay. I'm thinking you work in healthcare, right? And you're usually tooling around in healthcare. We were talking about the insurance industry and its pervasiveness. Yes. And its lobby in Washington, D.C., right?
Very powerful.
But, so sort of think about, changing healthcare, you start thinking you have to really go outside of healthcare. Maybe things outside of healthcare have to change. So how often do you find yourself, going outside of the healthcare realm and working on things that maybe you wouldn't consider? You know what I'm asking? Something bigger, or not bigger, but in a different dimension.
Well, let me say this to you. Everything is health.
Yeah.
Having safe housing is health.
Yeah.
Gun violence is a public health issue. Having safe food to eat, having fresh vegetables to eat is a health issue. Having safe parks is a health issue. Having good schools is a health issue. So what I've learned early on, if you really believe in the model of public health, everything is health. Whether people have adequate plumbing, whether they have housing or are homeless, whether they have a neighborhood that they can call their own, these are all health issues because they all impact the health outcomes.
Yeah.
And so, yes, structural racism is a health issue. And so do I find myself marching in protests that are things that people don't traditionally think about health? Of course, because there has to be, there is a connection, right? And people who understand how everything in our lives impacts our health, how we deal with or cope with. Every patient I see, I ask them whether they like their job or they hate their job. And that's because how they feel about their daily work has a tremendous impact on their health. So sure, yes, do I think voting is important? Do I advocate for voters' rights? Do I advocate for campaign finance reform? Of course, because everything is health.
Everything is health. I think we're, as a Bandar Center, we're looking for ideas like this and memes, and I think we're going to live off that one and think about that a lot, in weeks and months to come. That's a neat concept. I like that. So, you're kind of fond of saying the number, right? Like the 20 million and the 36,000 and the 500,000 households declare bankruptcy each year because of illness or medical bills, like an op-ed in the New York Times and stuff like that. But I kind of don't have a framework for that. Is there a percent? Why don't you talk in percentages? Because
what I mean? People get confused by percentages.
Yeah.
My husband was a high school English teacher. He said, throw out the percentages, literally. Talk about numbers so people can grasp the millions.
Yeah.
He used to chide me about that all the time. So I dispensed with that years ago.
Yeah. And then where do you get the figure? Where do you derive your data from?
Well,
what are your sources? Yeah, exactly. What kind of source do you like? Where do you go to turn to?
So the Census Bureau gives us lots of data, and then the Commonwealth Fund, Kaiser Foundation. There are lots of studies. It's not hard to find data, and physicians, we love data. We love to read studies, peer-reviewed studies that are published, that have had looked at numbers that are considered to be reliable, and in terms of how did you count, how many people were included, what was the volume. So I think that having data is important. If you're trying to make a point, you can't just make it up. You can't just pull it out the air. If we're going to make, as I said, policy decisions should be based on data. We certainly make clinical decisions based on data. If you decide on a patient, what needs treatment, you're looking for vital signs, you're looking for blood counts, you're looking for data. So
right.
I thrive on that.
That's the way. Yeah, that's the way you do it. Let's talk about Physicians for a National Health Program. You've had kind of a variety of roles in PHP, right?
PNHP, yeah.
PNHP. Were you the president of PNHP?
I've been the president on two separate times.
So I'm wondering how becoming the president of a national organization like that augments your activism and how it constrains it. Once you start speaking on behalf, of an organization, yes, right? Do you shy away from saying certain things, and you can say certain things better? Is that right, or you can talk about?
Someone once told me that higher you get, the closer you get to the leadership role, the harder it is to tell the truth.
Yeah, that kind of stuff. Yeah.
I don't find that because, you know, I think that some people who are to worry about those things, they do. But really, when I can no longer say what I believe to be the truth, then I don't want to do that anymore. So my feeling about Physicians for a National Health Program is I think it's an important issue, and I have stepped in to do whatever they have asked me to do. So if it's behind the scenes logistics, I'm happy to do that. I want to be a part of a movement that moves us closer to where we're trying to go.
Yeah.
When I've been asked to serve as president, I have. And because our national office is located in Chicago and someone needs to provide continuity, our presidents change every 1 to 2 years in terms of management of the staff. I do that because that's what's required. And so being committed to an issue means you're willing to do what's required to help make it successful.
Right.
But you know, so I am careful in my role at Cook County Health that I don't speak on behalf of the county government. I use a disclaimer when I say this is my opinion or a PNHP opinion as opposed to the County of Cook's opinion. So I am mindful of that. But my bosses know who I am and what I do, and when they decide that I have in some way offended, they may remove me, but they realize that I will not change my behavior because I've ascended to a leadership role.
Can I ask this? Is there a risk-taking involved with balancing those things?
I think there's always a risk. I think there's always a risk. But you have to decide, as always, what's most important.
Yeah.
Right.
Neat. Let me ask you one more question, and then we'll open it up to some audience discussion. So we're going to, you talked about this a little bit already, but we asked kind of a classic question in the Bandar Center, and it's this one, you know, do you think health care is a human right? And, you know, it's an easy answer, yes or no, but I really want you to talk about, you know, how do you convince the naysayers? You know what I mean?
Well, I believe it's absolutely a human right. And the reason I do is people have a tendency, you know, we're a very independent sort of, you know, I learned this phrase when I was coming up, pull yourself up by the bootstrap sort of country. And we think, you know, there's a mindset that I've got mine, you know, you should get yours. You know, I was able to climb and achieve, and so therefore you should be able to do so as the same. And I say that that's at our peril, that to not assume responsibility for the health and wellness of all of those in our community is at the peril for our own health and wellness. And what do you mean by that? Well, and I like to give, you know, common examples. I ask, you know, how many people ate out in a restaurant in the past week? And many times people have. And I say, well, do you know who prepared your food? Do you know who washed the dishes? Do you know the medical status of the person who did that? And do you know whether or not you were exposed to a contagious disease? Do you know who rode next to you on the train or the plane? And whether or not their cough was a cold or tuberculosis? So we can spend a lot of time and a lot of money, as we do in this country, excluding people from healthcare delivery, but we do so at our peril. And when we don't ensure that all of us have access to health care and the things we need, we jeopardize the health of ourselves and our family and the rest of our community.
Thank you. We have an audience here, and you know, in the audience there are PhD students, there are family practice doctors, there are people from just St. Louis. I was telling you before, it'd be neat if somebody was just walking around in the museum and happened into this, you know. But I want to kind of reach out to the audience and see, you know, what comments do people have? What are you thinking about? Is healthcare a human right for you? I wonder if anybody wants to start it off. Did you know I was going to do that? Go ahead. If you could, just say your name.
Hi, my name is Mark Fitzgerald. I'm a PhD student over the Healthcare Ethics Department. First of all, thank you so much for your talk. So if we're a group of people who decides that single-payer healthcare, or more broadly, fair and just access to healthcare is some sort of ethical goal, it seems pretty clear that ultimately what enacts that is some sort of legislative movement or decision. But prior to that, outside of other concerns for boosting other areas of public health and so on, what do you see as a way to affect some sort of change about access to healthcare in the time leading up to when hopefully that becomes then a matter of policy?
What do I see as a way? Well, I think that one of the problems is that the American public has not yet bought into the notion that healthcare is a right. I think that's a primary problem, because people are asking questions like, well, what's that going to cost me? Or what's that going to do for my health insurance? Or does that mean that I'm going to have to wait longer to get the care that I think I need? So we tend to have a very self-centered sort of look or view at this. And those are not appropriate questions if you actually accept the premise that it's a right. Because if you accept the premise that it's a right, then you start saying, well, how can we do it? You know, and I could tell you that we actually already spend enough money to do it, but first we have to accept the premise that it's a right. So I think that the first step is really getting getting society to be more introspective, to look at themselves. You know, I can talk these numbers about the millions of people, but really what usually affects people is when I talk about individual patients, and people can see themselves in those patients. Oh, that could have happened to me. Oh, that could have been me. So when people begin to see that even though they feel like they're in a pretty comfortable position right now, that none of us are guaranteed anything unless all of us are guaranteed. So it's really, how do we change that? So I really find that the most important step, because it will have to be some type of legislative process, is really changing the broad opinion of the American public about this issue, and to get us to stop looking so much about what does that mean for me, and have a broader view. So it's really where our society is right now that's the biggest problem why we don't get there. We could talk about the problems with the legislators, but the real problem is, because what I know is that when there are huge issues of social justice like this, when the public makes up its mind, then the legislation falls into place. That's how women got the right to vote. That's how we got civil rights legislation in this country. It is how we ended the Vietnam War. It is the only way that we get there, is when the public starts to make demands. Then the legislators figure it out.
What, do you have a follow-on to that, or what do you think?
Yeah, so I was just wondering, outside of, because ultimately it seems from what you're saying, the solution to this problem is a legislative solution. But prior to the legislative solution taking place, are there ways in which we can directly increase, in some sort of pocket of resistance, access to healthcare, other than just trying to change some form of consciousness about the issue or awareness or perspective? Is there some model in which, in an area, you could actually have a group of people decide this is a desirable goal and enact some sort of way to increase access to healthcare locally or otherwise?
Yeah, but the only way people enact it is through legislation. And so the question is, like, if one state did it, would other states fall in line? Or if one city did it, is that what you're...
City, state, or even, I don't know, if you were familiar with a local group.
Yeah, so, I mean, so there certainly had, you know, that was some of the mindset at Puget Sound, that some of the mindset of, you know, there have been various times where people have had this notion. I mean, even Kaiser Permanente, when they were first started, was a notion like that we would have a population of people and we would take care of them, and that would move the needle. But most of those things are not sustainable economically, and at the end of the day, they haven't sustained over time to the grand goals that we would like. So I'm not fatalistic about this at all. I actually believe we will get there, because I think that as things get bad, as the tide gets the fit gets tighter. In other words, as people become dissatisfied, people who thought they were comfortable find that they can't get the things they need, they begin to look, have a broader view. But as long as people feel comfortable and feel they have access to what they need, and the reality is that more than half the population had private insurance from their employer before the Affordable Care Act was enacted, and still more than half of the people in the country have access to health care and private insurance through their employer after the Affordable Care Act. What has changed is that the premiums have gone up and employers are offering fewer and fewer benefits. And as that happens, people begin to see how pernicious things can be, how pernicious the insurance industry can be. Those sort of things are more likely to move us than a pocket of committed individuals who say, we can do this. I encourage that pocket of individuals, but it's going to take a much broader movement to affect the change that needs to happen to really be impactful on the population as a whole.
Thank you.
Thank you.
Thank you.
I wonder if there's an activist in the audience who wants to talk about their experience. Who's out there?
I did just.
Yeah. Go for it. Just say your name, if you could.
My affiliations.
Yeah.
So I'm Catherine Matthews, and I'm an OBGYN physician with SLU, and I am very privileged now to be part of the Bandar team. I did want to say to you, there is work in Missouri to put Medicaid expansion on the ballot in 2020. And there has been work locally in this region, but we still have these much bigger systemic issues which make access to care difficult. I wanted just to hear your comments on some of the places where we have really high cost. Healthcare has become a way to make money in this society. It's a huge industry sector, even for Medicare and Medicare Part D and kind of prescription costs. Where do you see, and on my mind recently, it's been coming up as a most commonly read article in JAMA, the costs of academic medical centers. Where do you see some of the necessity of dealing with those issues, or what's your take on some of those concerns?
Well, so I think the first one, and I do want to say that the notion of expanding Medicaid in Missouri is very important. And it's important because it does move the needle. By not expanding Medicaid, Missouri allowed a segment of the population to be isolated. They don't make enough money to go out and buy insurance on the exchanges, and they make too much money to get Medicaid. And so you've left them permanently uninsurable and uninsured, and you've denied a segment, most predominantly of people who are struggling to get by without insurance. In terms of one of the huge cost centers, and a big source of frustration for me, is the pharmaceutical industry in this country. And I have to point out to people that the pharmaceutical industry is more profitable than the gaming industry in the United States. And I mean that the absurdity should offend everyone. But one of the biggest, and I would say one of the most pernicious things that is happening now is the swallowing up of small pharmaceutical companies. And when they swallow up these little companies, when big companies swallow up small companies, they are allowed to reprice and rebrand drugs that may be generic or dirt cheap, and suddenly they cost hundreds of dollars. And the classic example people have been talking about a lot is insulin, which cost a few dollars a vial, now costing hundreds of dollars a vial. And we actually have diabetics, young diabetics, dying because they stretch out their insulin or because they don't take insulin because they can't afford it. That's criminal. But there are multiple examples of orphan drugs that, I have talked a couple of times today about colchicine, which is a gout medication, which used to be pennies for a pill, and now is so expensive that we can't, even at Cook County, we can no longer provide people that medication to take on a daily basis. So we have the instance where you have a drug that's effective, a drug that works, and it used to be pennies and now it's hundreds of dollars. And so instead of giving it to patients, we no longer will dispense a monthly supply. We will give a maximum of 10 pills and say when you get gout, you can take a pill. And if you still have pain 2 hours later, you can take another pill. And then once it's better, you can take pills until those 10 run out. But then you have to wait until you have another attack. So instead of saying we'll prevent your attack, we say we're sorry you will endure that pain, and then when you get an attack, we'll give you medication, we'll treat you, but we can't afford to prevent it. So when we're making those kind of decisions about medicine, and it's all over profits, that should be offensive to everyone. But it is happening more and more. And I would point out that most pharmaceutical companies today are multinational companies. And we have the instance of them selling drugs in Europe or selling drugs in Africa or selling drugs in Canada for much less than they sell them here. And sometimes here they're selling them for maybe 3 or 4 times the price, sometimes it's 10 times, sometimes it's 100 times more expensive because we allow pharmaceutical companies to charge whatever the market will bear. So I think that one of the things, and why do they do that, is because we allow them to do that, and because they have it's a very powerful industry with a lot of lobbyists, and there are a lot of politicians who receive money for them. And until we demand that this industry be regulated in a more reasonable fashion, we will have people die because they don't have access to the medications they have. So I think that that's something that we need to advocate in a very powerful way against. Yeah.
Andrea, and then Cindy can be next. Yeah.
Hi, thank you.
Say your name.
My name is Andrea, and I'm also in the healthcare ethics program. I wanted to ask you your thoughts about sort of the logistics of a single payer system, and I'm thinking how the health economist Uwe Reinhardt, who is a big proponent of single payer systems. Yes, okay, so in his last book, which was published posthumously, his wife addressed this question as to what he thought about single payer in America. And apparently he was quite cynical about it, that while it would work in other countries and does work in other countries, it wouldn't work here.
People say that, you know, in Canada, if you have a line to get health care, that the Canadians say, well, as long as they know they're going to get what they need when they need it, they don't mind a line. But if Americans saw a line, they would reach in their pocket and say how much to get to the front. I'm not that cynical about the American public. People talk to me about, well, they have long lines in Canada. And I said, well, how long do you have to wait to get surgery here in the U.S.? And they say, well, you know, not as long. I said, we don't know. We don't know because we don't collect the statistics. We don't collect the data. We don't count it. Where Canadians actually say, okay, you're going to need your cataracts removed. They're not right now. You'll probably need them in about 2 years. Let's put you on the list. And then if something changes and they think that your cataracts have progressed faster than they anticipated, they'll push you up. But it's about saying, hey, you know, we have a limited resource. That's a reality. Let's figure out how to distribute it so that the people who need it the most get it first. If you have coronary artery disease, heart disease, and you need to have heart surgery, and this has been studied, it's written about, it's published, you know, if your primary care physician or your cardiologist say your need for heart surgery is urgent or emergent, you immediately get surgery within 48 hours. You move to the front of the line. I believe that the American public could adjust to such a system. What we don't know now is how long people wait for care they need. And we don't know because we don't track it, because we don't guarantee anyone except people who are incarcerated access to care. Okay? So I think that the logistics are, I'm not as cynical as Uwe. We had those conversations. I've had dinner with him and his wife. And Uwe and I have spoken together on panels before. Very smart man. He had a great understanding of the economics and he He actually attended Saskatoon University in Saskatchewan with Roy Romer, who was was the premier of Saskatchewan. So he had a real understanding of the Canadian system as well. But as I said, I don't share his cynicism about the American public. Thank you.
Hello, I'm Cindy Bitter. I'm St. Louis University Emergency Physicians. Back to the pharmaceutical point, I think it's very important to say that pharma is not charging what the market will bear. Pharma is charging what an artificial market would bear, because when Medicare Part D was passed, there was a statute in there that Medicare was not allowed to negotiate drug prices.
That the Secretary of Health and Human Services was not allowed to bargain or negotiate the fees for the pharmaceutical medications.
So Medicaid can bargain, the VA can bargain, Medicare pays about 80% more than the VA for the same medications. So everyone who's talking about market forces in medicine needs to understand that they have an artificial market.
Well, and that's because some of the people who worked on drafting that legislation immediately turned around to work for the pharmaceutical industry. Some of them came from the pharmaceutical industry, and because we don't have any statute that prohibits revolving doors, we allow people to work on legislation, write legislation, and immediately go work for the companies that most benefit from that legislation. It's a problem.
How do you respond when people say things like doctors need to stay in their lanes or doctors should stick to doctoring?
Oh, I love that. I love that. Because I want the people who are saying that to tell me what my lane is, because I'm advocating for my patients and trying to take care of our patients. And I don't think that there's anyone who has a richer knowledge of the harm created by our lack of a healthcare system in this country, by the devastation created by our allowing the profiteering in healthcare, than those who bear witness to it. Those are the doctors and nurses who watch the suffering of patients on a daily basis. So when people try to tell me to stay in my lane, I'm like, okay, I think I'm there. Where are you?
Love it.
Yeah.
Is there, yeah.
Hi, I'm Martha. I'm a JD, MPH, and I love that you describe yourself as an activist. I'm an aspiring activist. Yes, I absolutely believe healthcare is a human right. And I believe it's not a question of if, but when we get single payer. I mean, we, as a country, we can't afford to continue to pay the rates that we're paying. When we do get single payer, there's going to be a much greater incentive for the government to invest in preventive care. And based on your experience as the health director of a colossal metropolitan area, where do you see getting the most bang for our buck when it comes to interventions, when it comes to health initiatives?
Well, right, so I think that's a real important point, a very important question, and it's one that I have spoken about before, because I think that getting single payer and provide just levels the playing field, and then we have to begin to ask the question about what is effective care. Okay, so there's tremendous disparity. For example, you pick your procedure, so there's certain endarterectomy, which is a special vascular procedure that happens more in the Northeast than it does in, say, Texas and Louisiana. And why is that? Because there are more vascular surgeons in the Northeast than there are in Texas and Louisiana. Doesn't mean that it's more indicated. So I think that we need to ask those questions, and I think that we're going to find that they are more effective, and this always is distressing to residents. I am the attending physician on the wards a couple of times a year, and I always tell the residents that their role, however important it is in the lives of each patient they are taking care of, is trivial in terms of health in this country. And that's because you have more impact on the health of a population by ensuring that they have clean water to drink, ensuring that they have safe food to eat, ensuring that they have access to fresh vegetables than you do by making sure they have the right to see a doctor. And so we have to begin to talk about this issue I said before about everything being health. And that we at Cook County Health, one of the things that we've looked at is we have asked time and time again to allow the federal government, for the federal government to allow us to spend healthcare dollars on purchasing stable housing for our patients, because we have patients who we know if we could provide them with stable housing, that they would have much less difficulty with their heart failure. They would have fewer admissions for their diabetes. And our inability to do that has been problematic. And so as a society, we have to talk about what are the interventions that are effective. I had the privilege of knowing a gentleman who worked for the health service. He was a past president of the American Public Health Association and was sent to rural Mississippi in the early 60s and to look at health care in a community, a rural community. And he decided the most important thing was he bought a tractor. He wrote a prescription. He used pharmaceutical dollars to buy a tractor, because there were people who had the strength and the will to take care of themselves but didn't have the tools with which to do it. And that by buying them a tractor, they could plow the land that they had and they could feed themselves. And that was more important than buying more drugs. They sent him back to New York, but it was an effective tool. It worked. So I think that that's exactly the question we have to have. Once we have made the decision that everyone should have access to health care, what is the most important intervention we can do to improve the health of the country? We're looking at a country that's struggling with opioids. We're looking at a country that struggles with obesity, and we're looking at a country being devastated by diabetes. We really need to be more reflective about the interventions that we think will work and make a difference.
Yeah. Thank you, Martha. So let's do one more. And then we'll do the research.
You touched on this a little bit earlier. I'm a SLU student here, sorry. But you said that racism was a public health issue, and I was wondering if you could touch on that a little bit more, and if race has an effect on access to public health care and insurance.
So we know that, so I'll give you one of the statistics that bothers me every day, is that women's survival with breast cancer. A white woman who is a high school dropout has better survival statistics than a black woman with a college degree if they both get breast cancer at the same stage. So why is that? And because we don't know why that is, it means we don't really understand all of the nuances of the healthcare system that we work in. We know that someone of color, particularly black, is less likely to be offered invasive procedures following a heart attack, and that their outcomes are not as good. And that doesn't matter whether the provider, the physician, is black or white. They're less likely to be offered invasive procedures. We have to begin to have those painful discussions about what happens. We talk about unconscious bias, and we all have unconscious bias. People make assumptions about people. I come from an actually very diverse background. Neither of my parents were born in this country. But people make assumptions based on their appearance. I know that when I walk into a room, the first thing people see is not the chief medical officer of Cook County Health, not the national coordinator of Physicians for a National Health Program, not the president of Health and Medicine Policy Research Group, not the winner of awards, humanitarian awards, or whatever. They see a black woman and they make assumptions. And based on that, that has a tremendous impact on what services I'm offered and how I'm treated. Until we can make adjustments, so learn to accept, acknowledge that we all have unconscious bias, and try to, to rail against them when we're making plans or assessments about what the needs are of an individual, we will not deal with the disparities of healthcare in this country.
Thank you.
so much. With that, let's conclude to Claudia Fegan. Thank you.